Welcome, everyone. Good afternoon. Thank you for joining. My name is Angelica Cardenas, and I'm a health educator for community health at Atlantic Health System. Today's webinar, Urinary Incontinence, a Common Issue Meets Practical Solutions, is presented by Jenna Silverman, pelvic floor therapist at Hackettstown Medical Center. Before we begin, I have a few announcements. Please know that this webinar is being recorded. All participants are muted. If you have questions, please use the Q&A for questions or the chat button for comments. We will try our best to get through all questions at the very end of the presentation. At Atlantic Health, we've combined expert care with comfort and convenience to offer a thoughtful mammogram experience that prioritizes your health and your well-being. With advanced breast imaging technology, we ensure greater accuracy and comfort. Plus, we make booking stress-free with easy online scheduling and flexible appointment times at locations near you. Finally, before Jenna begins, we'd like everyone to please take a quick poll. Please take a moment to answer the questions you will see on your screen momentarily. Your answers will be anonymous. All right, the first question is, all of these strategies are bad for bladder health except for A, hovering over the toilet, going to the bathroom as soon as you feel the urge to go, urinating for a minimum of 8 to 10 seconds, or D, pushing your urine out forcefully to make sure every drop is out. Question number 2, true or false? Artificial sweeteners can negatively affect bladder function. A, true, or B, false? I'll leave that open just a little bit longer. More than half of you have participated. Thank you for that. Great. Thank you. All right, thank you for participating. And now I will turn it over to Jenna.
Hi, everybody. My name is Jenna Silverman. Thank you for coming to today's presentation. Very passionate about pelvic floor health. I work at Hackettstown, as Angelica mentioned, and I hope you enjoy our presentation today. Okay, I do have some objectives for today. So first, I'd like us to be able to define what incontinence is, and there's a couple different subtypes of incontinence I'd like you to know about. We'd like to go over some strategies to decrease urge and stress incontinence leaks. We'd also like to understand the purpose of what pelvic floor therapy is and its relationship with incontinence, and also to understand the basic anatomy of the pelvic floor muscles and the urinary system. So let's dive in. There we go. So my name is Jenna Silverman, as I mentioned before. I am a pelvic floor occupational therapist. I work at Hackettstown Medical Center, and I have been here for 11 years, since 2013. I started here with working with the orthopedic population, the neurological population, and then I decided that I wanted to make a switch. So in 2021, we started doing some additional construction here at Hackettstown, and now I have a wonderful private treatment room, and I'm able to see the pelvic floor population. I could see the female population at Hackettstown. I do want to point out that there are practitioners who do serve the male population at various parts of Atlantic Health System. So if you'd like more information on that, we can give you some more towards the end. But I do see the female population at Hackettstown. And I am both a pregnancy and postpartum corrective exercise specialist, as well as a certified sexuality occupational therapist. So I have a couple additional credentials in addition to being a pelvic floor therapist. I do have my email address listed there. I know the PowerPoint will be emailed later. So if you do have any questions, you can feel free to reach out to me. Just let me know that you listened to the webinar, and we can go over any questions that you might have. Okay, so I just want to go over really basically how the urinary system works. So if we're looking at the screen, we see two kidneys. The urine is going to be, the kidneys filter out waste from the body. So you ate, you drank, you did everything you needed to do during the day. Your body makes the urine, it gets filtered through the kidneys, and the urine goes down here, all right, through the ureters, where then it's stored in the bladder. All right, and that's when we have some issues with incontinence, when we're trying to store the urine and the urine does not want to be stored anymore. So the urine is stored in the bladder. There's nerve signals that say bladder to the brain, hey, I need to use the bathroom. You use the bathroom. On average, it's about 2 cups of fluid. Once you're sitting on the toilet, everything is relaxed. The bladder can contract and the urine can pass out. It is important to note that your body will continuously make urine. So it's always easy to convince yourself that I just used the bathroom, and then maybe 10 minutes later, you go back and you sit down and there's a couple more drops, right? And you say to yourself, see, I did have to go. I did have to go. But we can actually convince ourselves that we had to go when we really didn't. And we'll talk a little bit more about that. But you will always be able to take out and make it a little bit more urine because your body continuously makes it. Restricting fluids can also backfire. I have a lot of my ladies who say, oof, I'm going to a wedding. I will not drink anything all day long because I will not go to the bathroom. And again, our kidneys will continuously make the urine. And now what you're doing is you're making concentrated urine that's going to sit in the bladder for longer and irritate the bladder, irritate the urethra, and could potentially cause some discomfort on its way out or additional leaks. So restricting fluids can definitely not be is definitely not a good strategy to use, although I know many women do use it, and men alike. So keep drinking that water. All right. Okay, so what are we here to talk about today? Urinary incontinence. What is it? It is defined as an involuntary loss of urine that's usually sudden. It kind of happens and you go, because you didn't realize it was going to happen, or maybe you really had to use the bathroom and you just didn't get there in time and you knew it was going to happen, but it came before you were able to make it to the toilet. So it could be a little bit where it's just maybe a spot or two, a drop or two on your underwear, and it can be a large amount. So we kind of identify it here in the clinic. So I might say, how much was your leak? Was it a tablespoon? Was it a full change of clothes? Was it just the underwear, or was it you had to, do a deep clean of the couch because it got everywhere? So it can really range from just a little bit to a full where your bladder just completely empties. It can be really debilitating for many reasons, but it is also a really big fall risk. So if someone especially is waking up in the middle of the night because they have to urinate, kind of late, it's groggy, the lighting's not good because we're sleeping, and now you're getting up. If you have a little bit of a leak, a little loss of urine, and you fall, that's bad for many reasons. Then we might have an additional problem in addition to having that urinary leakage. Maybe now we have a fractured hip or we have a concussion, something like that. So this seemingly harmless, oh, I just leak a little bit, really can be debilitating and detrimental. It can also be a social stressor. I have a lot of people who say, I don't want to leave the house because I'm afraid I'm going to have an accident. I don't want to leave the house. I don't want to go to a family wedding. I don't want to go to a party because I'll be in the bathroom every 5 minutes, or I don't want to have to stop every 5 minutes to drive, because I need to use the bathroom, or I don't want to go because I have to use pads and that's embarrassing. I will not wear a diaper in front of my family. So it can be a really big social isolator, because something as simple and common as people need to use the bathroom, we need to get rid of our waste, can now become very isolating and destructive in that sense. It can also be all consuming. I have people come in and they say, I think about toilets and urinating all the time. I know where the bathroom is in Kohl's. I know where the bathroom is in Target. I know where the bathroom is, in ShopRite. I know them all and I go to every single one. And it can really just be all consuming. Or you think to yourself, okay, I'm going to rent a Kohl's. I use the bathroom then, and then I have about a half-hour drive until I get home, and I can use the bathroom again. And the whole day is planned around going to the bathroom, and it can just take over someone's life. It can also be expensive. So urinary pads cost money. If you have to change your clothes a lot, you're doing more laundry, that's additional money. If you are having accidents involving the furniture or bedding or upholstery in the car, it can be expensive to also clean that. So in addition to just being something that can be slightly embarrassing, or it can be a fall risk, or it can be something that's isolating, it can also have an expensive component as well. There are a couple different types of urinary incontinence. The two main ones are urge incontinence and stress incontinence. Urge incontinence is one of those is one of the ones that you say, "Oh my gosh, I can't talk to you right now. I have to pee right now," and it's extremely it comes on quickly, and it's really habit formed. It kind of starts when your mom says to you, "I know you don't have to go, but go on and just try. Just try. Well, we're going to go on a car trip. Oh, just try." And we train ourselves to use the bathroom before we actually need to use the bathroom. And this over time can cause urge incontinence, which is habit based. Urge incontinence looks like this: you're driving home from work, you're driving home from your daughter's house, everything is fine. The second you get home, you say, "Oh my gosh, I have to go now," and you are running to the bathroom. That is urge incontinence. As you're running, you're leaking a little bit of urine, or as you're in the bathroom, you're starting to pull your pants down, and you're leaking a little bit then. So that's urge incontinence. Stress incontinence is more of the one that we hear about after childbirth or as we get older. So you sneeze a little, you cough a little, and some urine comes out. I like to point out that it is not a normal part of aging, but it is a common part of aging as everything starts to get a little bit weaker. But pelvic floor muscles, bladders and muscles, we can strengthen those through pelvic floor therapy and a couple other things. So stress incontinence is the one that, I cough, I sneeze, I laugh, I stand, I leak a little bit. Urine urge incontinence is, "Oh my gosh, I have to go right now or I'm going to pee my pants." So going back to urge incontinence, a lot of it is habit formed. Okay. The characteristics are using the bathroom all the time. That's I'm going to Kohl's, I'm going to Target, I'm going to Michael's, I'm using every single bathroom. Leaking on the way there is kind of a effect of panicking. "Oh my gosh, I have to go right now." And your body starts to panic. It's the people who know where all the bathrooms are. It's the people who say, "Okay, I'm going to plan my trips around the bathroom." It's also the just in case pee. And then it does also increase your chance of waking up in the middle of the night to urinate. So that's called nocturia. So pre-menopause, unless you're pregnant, 0 times a night is your normal to get up to pee. After menopause, normal is more like 1 because of the hormone shift. So what that means is you wake up, I should use the bathroom. I use the bathroom. Not, I'm up because I heard the dog barking, I heard thunder, and now I'm awake and I should go. But often going in the middle of the night is also not a good habit, because you want to be sure that you're getting that restful sleep. The just in case pee, like I said, that's what your mom told you to do when you were little, and it's what you do before you go to do your activities. And what we're doing is we're training your bladder to hold less fluid and therefore go more often. Stress incontinence is usually the cause of a weakness. It could also be because of spasticity of pelvic floor muscles, but usually it's weakness, and it happens when there's a change in the intra-abdominal pressure. So cough, laugh, sneeze when I'm going to sit to stand, or when I'm holding my breath to get out of bed because I really have to work to get up to sit. When you have both urge and stress incontinence, we call that mixed incontinence, and some people do have both. And then there is also a subcategory I like to mention called functional incontinence. This really isn't a problem with incontinence as much as it is mobility. So, for example, someone who just had a hip surgery, they might be fine with their urinary system, but maybe they can't get up to the bathroom in time. Or maybe someone had a stroke and it's hard for them to stand up to go to the bathroom in time, or to ask for help to get to the bathroom in time. So it's a subcategory I like to mention, even though urge and stress incontinence is usually what we're going to be focusing on in therapy. Okay, so how do we fix some of these things? So I just told you that urge incontinence is a habit-based issue, right? So we have to try to take back with our brain to be in charge and our bladder to go take a back seat. So I usually say mind over matter, brain over bladder, right? So right now, because you've been doing the just in case pee your whole life, or I'm going to go, I don't want to go on the airplane, I don't want to go in the car, I'm going to go on a 5-hour trip and I do not want to use the bathroom, so I'm not going to drink anything and I'm going to pee right before I leave. because you've done these strategies for so long, we can actually train our bladder to hold less fluid. So I usually say, if this water bottle here is 24 ounces, I know that I didn't just drink this, 5 minutes ago. I know that my bladder doesn't really need to go, even if I'm getting that urge. So I need to learn some urge suppression strategies, and you can walk away with those today. So let's just say, what time is it? 12:15. Let's just say I know that I went at 12 o'clock, but my bladder is telling me that I really should go again. It's going to give me an indication. Maybe it says, okay, my bladder can hold 16 ounces, but I'm going to get a signal around 12 ounces that says, hey, you don't have to go right now, but eventually you're going to have to make to the toilet. But I'm giving this presentation. I cannot go to the bathroom right now. I have to hold it. My bladder will tell my brain again at maybe 12 ounces or 14 ounces, you really should think about going to the bathroom soon, right? And then I can say, it is a good time for me to use the restroom. I will excuse myself, go to the bathroom, and come back. If my bladder gives my brain the signal that says, hey, you've got 8 ounces, I'd like you to go to the bathroom now, and I listen, my bladder laughs and says, well, now I don't have to hold 16 ounces. Now I can hold 12 ounces. I'm going to hold less and less and less. And she's going to go every single time. And so now all of a sudden you have this bladder that's supposed to hold more fluid, and you've trained it to hold less. So we can do some urge suppression strategies to try to increase the volume that your bladder will hold comfortably. We want to stretch it little by little. So for example, if you're someone who urinates every 15 minutes, I do not want you to wait 2 hours tomorrow. I want you to slowly build it up. So maybe it's every 15 minutes today, but maybe next week it might be every half an hour. And the week after that, maybe it's every 40 minutes or 45 minutes. And slowly you're going to try to retrain. Normally, we want to go between every 2 and 4 hours. Okay, so that's kind of our average range, especially if you're drinking a lot of water. It's closer to the 2 hour mark. But we want to figure out how we can stretch that out a little bit. So brain over bladder, right? So we want to get that bladder in the back seat. We want our brain to come back in charge. So for example, I tell people, use logic. Did you drink this whole 24 ounces in the last 15 minutes since you went? No. The answer should be no, because you shouldn't be chugging fluid. Number one, you want to drink it slowly throughout the day. But you can use logic and say, there's just no way I drink that much water. Okay. You can also wait maybe 5 minutes, maybe 1 minute. Maybe you look at your clock and you say, okay, I feel the urge to go. Bladder's telling brain I have to go, but I'm consciously going to wait 2 minutes. In 2 minutes, I will walk slowly to the bathroom. I will do what I need to do. Just by giving that brain the permission to say, okay, I'm in charge, the bladder takes that back seat, which is what we want. We don't want to go to the bathroom every 15 minutes. We want to enjoy our family functions. We want to be able to work from home without having to take a break every 5-10 minutes because we have to use the bathroom, right? Because again, you're going to convince yourself, I had a couple tinkles in me. I use the bathroom, and I'm going to say, no, your bladder keeps making urine. I'm sorry, your kidneys keep making urine. You didn't really have to go. So even by looking at your clock to say, I will wait 2 minutes and I will walk calmly to the bathroom, your brain starts to come back online. I also offer a distraction. So sometimes I say, okay, bladder, I hear you, but I'm going to finish looking through the mail. I'm going to finish, reading this paragraph. I'm going to finish the TV show. And then when I will stand up and I will go to the bathroom calmly. So I hear what you're saying, bladder. I will listen to you, but I'm going to finish this task first. So instead of giving it a time frame, you give it a task. Also, adding a short step in a known routine can help to kind of break it up a little bit. This is like someone who has, it's called key in the door phenomenon. You're fine all day at work. You're fine in the car. The second you put your key in that door to go in your house, your bladder says, like, oh, that's right. This is a comfortable position. I can urinate now. I can let it go. I've been holding it too long. And your bladder just lets go. Right? It's called key in the door phenomenon. And it's big with teachers and nurses who do have to hold their bladder for even longer time. So even if you say, I hear it, I know I need to use the bathroom, instead of opening that door and running right in, do something different, anything different. So maybe that's the time that you go through the mail. Maybe that's the time that you answer that text message or email that you were supposed to do 4 hours ago. You do one quick thing and then walk calmly to the bathroom. And I know you hear me say calmly to the bathroom. She's saying that a lot. I'm telling her that I have to pee so badly that I want to run to the bathroom, and she's telling me don't panic and calm down. Bladder needs to take that back seat. Bladder needs to go and take a break. The brain needs to be in charge. So if you panic and you start to run, oh my gosh, oh my gosh, oh my gosh, I'm going to pee my pants, that's when you're going to leak a little bit. Okay. So you're walking calmly to the bathroom. If you've seen a pelvic floor therapist and you know that you have no trigger points, or if you have no pelvic pain, you can do some quick pelvic floor contractions, also known as Kegels, where you kind of squeeze, 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 and you say, okay, bladder, brain, I hear what you're saying to me, but I don't have time to go right now. That can be a good strategy for someone. I do caution that if you are someone that does have pelvic floor pain, Kegels are not for you. So I encourage you not to do those. We talked about stretching it 10, 15 minutes every week and some things to avoid. So we talked about the just in case pee. Don't do it. It's terrible. If you're doing it, try really hard to avoid that. So if you're someone who goes, I woke up at 7, I use the bathroom, and now I'm going to go to the store. It's now 9 o'clock. Maybe you can use the bathroom then. But if you're going to leave the house at 7:30, did you really drink enough fluid between 7 and 7:30 to really have to go? Or can you wait, a little bit longer? So are you going just in case, or are you going because it's a habit, right? It's a habit, or you really have to go. There are bladder triggers and there are bladder irritants, which we will discuss in a little bit. Bladder triggers are more like every time someone mentions urination, I have to use the bathroom. Anytime I'm cold, I have to use the bathroom. Anytime I hear running water, I have to use the bathroom. So if we know that that's going to be an issue, we can know, okay, I'm going to wash the dishes. That's water. I'm probably going to have to pee a little bit. Is it an appropriate time for me to use the restroom? If not, I know that I don't really have to go. Fluid restriction, we already talked about your bladder. Your kidneys will continuously make urine. So restricting fluid concentrates your urine, makes it a little bit more uncomfortable for the bladder lining and also for the urethra. So it's more uncomfortable to hold it without drinking enough water. All right, stress incontinence. This is the I stand and I leak and I cough, I sneeze, I laugh, etc. Okay. This one is a little bit harder to treat because we're working on mostly weak muscles. There are some muscles that have stress incontinence that are so spastic and clenchy and tight that can cause stress incontinence. But usually when I see these ladies, it's because of weakness. So there's a different treatment if you do have that tightness, but we're going to focus a little bit on the weakness here. So we can do something called the knack maneuver. So that's, I know I'm going to sneeze. I'm doing that. I know I'm going to sneeze. I anticipate it. So before I sneeze, I can do a Kegel. So I'm going to grip and gather my pelvic floor, and then I'm going to cheese, right? So I'm going to sneeze. And I can Kegel to change the intra-abdominal pressure to kind of tighten everything, and I don't have that leak. And sometimes that knack maneuver is enough for someone to learn and to get good at, and that's good enough for them. Okay, I know I'm going to cough. I know I'm going to sneeze. I will do this knack maneuver. I will do this Kegel, and I can avoid leaks. One of my favorites is exhale on exertion. That just means whatever the hard part of whatever you're doing is, don't hold your breath. So for example, if you're sitting right now, I challenge you to hold your breath and stand and see what that feels like on pelvic floor. And then sit back down. And then this time, inhale, exhale as you stand. So as you're standing, exhale, kind of like my picture over here. She's exhaling as she's doing the hard part of the exercise, right? If you hold your breath, all that pressure goes down on pelvic floor. And if you have a bladder that's ready to leak, you're going to leak a little bit. If you're exhaling as you're standing, pressure's coming out here, not going out on pelvic floor, and you're going to decrease your risk of leaking. Everyone holds their breath way more than they think. You're opening a car door, you're holding your breath. You're tying your shoes, you're holding your breath. You're picking up a baby, holding your breath. You're trying to stand up from the recliner, you're holding your breath. So be aware of that and see if you can work on exhaling to decrease the pressure on pelvic floor to decrease the leaks. We want to have good bladder habits. We're not trying to go all the time, but we're also not trying to go every 5 hours, okay? We're not trying to wait too long because then the bladder is very full and then you're more at a risk for leaks. So we're trying to aim between 2 and 4 hours. If you're drinking enough water, it's going to be closer to the 2 hours, but we're not trying to wait too long. If you're coming in for therapy and you've been assessed and you have no pelvic pain, no trigger points, we'd put you on like a Kegel regimen. So Kegel is you're gripping and grabbing pelvic floor and then I'm relaxing, gripping and grabbing pelvic floor and then I'm relaxing. If someone has pelvic pain, it's like a bicep that's going out and in, but not fully extending. So then we're only strengthening in this half plane, which is no good. And we can cause increased trigger points, increased pain. We also want to make sure that we are fully emptying our bladder. We are not trying to push the pee out. When your body gets the signal that they need to urinate, you're going to walk to the bathroom calmly and slowly. You sit down, certain muscles relax so that your bladder can contract and get the pee out. If you're sitting there and you're trying to push the pee out because you've got better things to do, you're messing with the reflex, and we're trying not to do that. So instead, you can do something that's it's a positioning strategy where you're leaning. I don't know if I'm going to be able to see it. Where you lean forward a little bit, kind of with your forearms on your legs while you're on the toilet, and that tips the bladder forward to get those extra couple drops out. So no power pushing. Don't push it out. Try to lean forward, tip that bladder naturally to get the rest of the urine out. We also want to, if you're coming in for therapy, we want to improve the quality of bowel movements. We don't want to have constipation. It's a small area in the pelvic floor that feces can hold space there, and then the bladder can kind of feel more full and more irritated, and you'd be likely to need to use the bathroom more often, and it can also have some more leaks that way. If you're coming in for stress incontinence for pelvic floor therapy, we'd also work on core muscles, glutes, spinal mobility, kind of a global strengthening program. Research shows that the deep core muscles and the obliques are known to help decrease stress incontinence. So we would incorporate some of those muscles into your exercise regimen. And let me see. There we go. Everyday things that are ruining your bladder. It's a lot of them. My favorite are the bladder irritants. If we look down that list, they are all the fun things, right? So I'm going to say all these things can potentially irritate your bladder and irritate your urethra and make you want to go more often and make it more uncomfortable. So people who have interstitial cystitis and they're going to the bathroom all the time, they go on a diet to reduce all of these fun things. So I have people who say, okay, I hear you. Caffeine, bladder irritant. I got it. I'm not giving up my coffee. And I say, okay, I have to respect that, but just know you're going to go to the bathroom a little bit more often. But look at the list. It's all the fun stuff. So smoking, drinking, caffeine, chocolate, carbonated beverages. So my friends who say, oh, but I don't like water, but I really like seltzer. Well, carbonation can bother the bladder and the urethra. Citrus foods, acidic foods, spicy foods, and artificial sweeteners. So my worst nightmare is when someone comes in with a big old 42 ounce of powdered iced tea that they put in their own artificial sweetener, and we've got caffeine, we've got artificial sweetener, we've got a lot of fluid that we're going to overload this poor bladder, and it's going to be angry. Okay, so I say that these are bladder irritants, sure, but they might not be yours. So if you're going through life and you're like, man, every time I eat a nectarine, I really get uncomfortable. Nectarines might be your bladder irritant, but maybe chocolate's not. So they exist, they might not be yours. So a doctor might say, get rid of all of them for 2 weeks, slowly reintroduce them and see which ones cause your symptoms. So that is an option. You kind of do an elimination diet to see what was the thing that was bothering you. We talked about some of the habits that are dooming you for your bladder habits. The just in case pee, you heard me talk about it. We want to really go when we only have to go, not because you don't want to go in ShopRite. All right, they have toilets for a reason. Cluster pee. That's when you use the bathroom multiple times in a row to make sure that you're really empty. So for an example is I go up to bed at 8 o'clock and I read a book. So I go up, I use the bathroom, I read a book for half an hour. I'm done reading the book, I go to the bathroom again, and then I brush my teeth. And then maybe I play on my phone for 10 minutes, I go to my bathroom again, and now I go to sleep. So that's a cluster pee. You can take all three of those urination, attempts, and you can make it into one. All right. So I understand we want to make sure we're really empty before bed, and the last thing you should do before you go to sleep is use the bathroom, but we want to try to get away from that cluster pee. Okay. Holding too long, more than 4 hours, can give you increased chance of leaking, and going too often is training your bladder to hold less fluid. The key in the door syndrome, that's when everything's good and dandy. The second you pull in, you got to go now, right? Do something to distract yourself. Play on your phone, answer an email, call your friend for 5 minutes, walk in the door calmly, walk to the bathroom, do your thing. Hovering. I yell at everybody who comes in and tells me that they hover. So you get the signal that you need to use the bathroom, great. You walk calmly to the bathroom, awesome. You pull down your pants, good. You're gonna sit down and you squat over there, you hover over there. No, thank you. You are telling your legs to stay on. You're telling your core to stay on, and your bladder's like, you guys are supposed to be turning off so that I can do my thing and get the pee out of me. And you're just messing with the reflex. So I don't care how much paper you have to put down on that toilet seat. Please sit. So no more hovering. Thank you very much. Power pushing we discussed. So that's when we're pushing the pee out. Nope, we're trying to sit, relax. Everything comes out naturally. Incomplete emptying. Sometimes that's when we're rushing, or sometimes maybe due to a prolapse or something like that, we have a little bit left there. That's when we can use that lean forward strategy to see if we can get rid of that. That's a kind of a different kind of leak as a post void dribbling. When you urinate, you think everything is out, you go to stand and a little bit more dribbles out. It could be because of a prolapse or something else going on. So incomplete emptying can cause a little bit of a leak as well. So if we fully empty, we can avoid that. Restricting fluids, we know how we feel about that. And then the dietary choices, those are those bladder irritants. Again, I've got some people who say, I'm not giving it up. And I say, all right, just know that it's going to irritate you a bit. So we talked about bad habits. Let's talk about some good ones. Go only when you need to go, but don't hold it too long. So I get some people who are obsessed with this. They say, Jenna, you told me not to go, so I'm holding it, and I held it for 6 hours. And I say, no, don't do that either. So you get the urge to go. I want you to just monitor, check in. Like, did I have a giant, 32 ounce, 42 ounce, 64 ounce water bottle slowly over the past 2 hours? I probably do have to go. Did I just use the bathroom 15 minutes ago? I probably don't have to go. We're trying to go every 2 to 4 hours, depending on how much you drink, and 0 to 1 times at night. So post-menopause, you're looking more towards the 1. If you're pregnant, you get a pass on this one because baby's pushing on bladder and you don't get control over that. A little test is count how long your urine stream is. So we want a minimum of 8, better yet 10 seconds. And I mean real seconds, real Mississippi's. Thank you very much. So sit, do your thing, and I want you to go 1 Mississippi, 2 Mississippi, 3 Mississippis. If it is not 8 true Mississippis, you did not need to go, and your bladder just won. Okay? We got to get that brain back on board, right? So if you're going down and you say, okay, 12 seconds, all right, you didn't really need to go. You did. Good job. I have my coworkers, I have my family members, I have my patients who say, Jenna, I did a 13-second pee. I did have to go, I promise. And I say, okay. Or they say, oh, I only went 4 seconds. I did not need to go. I'm sorry. And I say, it's okay. Because we don't know these things. No one talks about these things. And then you meet me and other pelvic floor therapists, and we talk a lot about it. We want to get these good habits back up. So we want to count your voids at least 8 seconds. 10 is even better. Usually your longest void will be in the morning because you've been hopefully sleeping all night. Or if you're drinking a lot throughout the day, you might have longer voids, but we want to have at least 8 to 10 seconds. You need more water than you think. When people come in, I say, how much water do you drink? And they say, oh, a ton. I drink like 32 ounces. And that, my friend, is not enough either. All right. I told you that you're going to make urine no matter what. You might as well drink some good water for your body. General rule of thumb is you take however much you weigh divided by 2. That's how many ounces you need. So for easy math, if you're 200 pounds, you need 100 ounces of water. If you're 100 pounds, you need 50 ounces of water. Be mindful that we are not chugging that water. We are drinking it slowly throughout the day. You might have heard in the past, oh, see how strong your pelvic floor muscles are. Go ahead and do a Kegel. Stop your urine flow as you're going. Please don't do that either. That's also messing with the reflex. We're trying to get the pee out, and now you're trying to confuse your body to say, nope, keep it in because I want to see how strong it is. So please don't do that one. I will tell you how strong your pelvic floor muscles are when you come in to see me or any other pelvic floor therapist. Also, we discussed bladder irritants. If you know that a certain irritants are yours, right? Maybe it's the artificial sweetener. Maybe it's acidic food. If you know what your triggers are and you can remove them, you'll be better off for your bladder habits. All right, something else we don't talk about. How do we sit on the toilet? All right. You'll see in this picture here, this is something called a squatty potty, excuse me. It is a commercial product that is available for bowel movements specifically, but also for urination to put your body in a good optimal position for going to the bathroom. Notice I have no hovering. She's sitting down on the toilet. Okay, so we're getting everything in a good position to void, defecate, do whatever you need to do. For the squatty potty, you'll notice that her feet are nice and flat. She's got her knees above her hips. These will cost you maybe $25 to $40 depending on if you get the fancy bamboo one or one that has the adjustable height, etc. You can also take a small garbage bin and just turn it on its side, and you can just use that as well. As long as your knees are higher than your hips, you're in a better position for voiding. Mostly for bowel movements, but especially if someone needs a little help to fully empty of urine, that squatty potty gives you a good position to do the lean forward to get those last drips out. Let's see. We talked about the post-void dribble. So we can do the lean forward. That helps. There's another strategy. It's a little bit more cumbersome, but it is called the double void. That involves I did my thing. I urinated. I feel like I got it all out, but I might have a tiny bit. I leaned forward. I couldn't get anything else. You wipe, do whatever you need to do. Stand up, walk away, come right back. So kind of take 3 steps, sit back down, and sometimes that's enough to kind of shift everything to allow those extra drops to come through. Okay. And how does this relate to the pelvic floor? So the bladder itself is supported by pelvic floor muscles. Some muscles need to be strengthened to avoid the incontinence, and some of them might be lengthened. If they're super, super clenchy and tight and spastic, we need to lengthen them. We want them to glide as much as they're supposed to so that they're not putting too much pressure around like the urethra. We're trying to make sure that everything is nice and mobile so that it doesn't get caught up there. Pelvic floor. So everyone has a pelvic floor, males and females. So they're kind of a sling of muscles, ligaments, connective tissues, nerves, etc. They run from pubic bone to the tailbone, and then the 2 bones, they're ischial tuberosities, but if you kind of put your hands underneath, you kind of feel those 2 round bones, also known as like the sit bones. In men and women, the pelvic floor is going to hold and protect bladder, the rectum, and also in women, it's also going to support the uterus and the vagina as well. And how can pelvic floor help my incontinence? Okay. So when someone comes in, we're going to talk about all those habits that we've already talked about today. And I'm going to say, do you hover? Do you strain? Do you push your pee out? How much water are you drinking? What kind of things? Is there caffeine? Is there chocolate? Tell me about your diet. And we're going to dive into these habits because, again, no one really talks about this, right? We're talking about pee. We're talking about poop. We're talking about pain. You can come to pelvic floor therapy for painful intercourse, for someone who has a prolapse, all kinds of different things. So we're going to talk about incontinence today. So I want to know all your bladder and bowel habits. We're going to identify the good choices and see if we can fix some of the not so good choices. And then we're going to do some different techniques. There are external techniques and there are internal techniques as well. Again, I only see the female population, so I don't do any rectal work right now. There are pelvic floor therapists that see men, and that would be internal work is done rectally. There are also pelvic floor therapists who see females and the work is done rectally. Right now, I only do vaginal work for release of trigger points. That would be if someone has a lot of clench, a lot of spasticity, a lot of tension, we can release those muscles, kind of like a trigger point in your neck. We can release those muscles so that they move a little bit better, they glide a little bit better, and the pelvic floor is not super, super clenching. If someone has no pain, no trigger points, and we're just working on strengthening, we go over the right way to do a Kegel exercise. Make sure that you're fully lengthening so that you're not shortening muscles and causing a trigger point. Sometimes people have some fascial constrictions in the abdomen from maybe a previous surgery, something like that. So we can do some external work on the abdominal cavity to see if we can free that up. And then global exercises. We can do strengthening of I can give you exercises for years to do different muscles to target what we want to get you better. We also do have certain modalities to enhance treatment. So one of them is biofeedback and one is real-time ultrasound, which you'll see on the next slide. Let's see. There we go. So biofeedback is cool. If I tell you bend your elbow, straighten your elbow, you can do it, right? Because you can see it. If I say, go ahead, squeeze your pelvic floor muscles, some of you are going to be like, I don't even know where those are. Where are they? With biofeedback, there's nothing internal, but we do extra perianal sensors. So there's the two kind of sticky looking, kind of like stim pads or a sticker that go on the outside of the anus, nothing internal, one that goes on the inner thigh, one that goes on your belly. And I'm going to hook you up to this computer so you can kind of see this computer monitor here. And I'll say, go ahead and squeeze your muscles, and you'll tighten your pelvic floor muscles. And on the screen, you'll see there's a line that goes up. And I'll say, go ahead and relax your pelvic floor muscles. And on the screen, you'll see that the lines are going down. It kind of looks like this. I don't know. You might not be able to see it because of the background. All right. Well, forget that. Oh, wait. There we go. Oh, so if I say, nope, it went away. If I say squeeze, you see the line goes up. If I say relax, you see the line that goes down. And so even though you can't see these muscles, you can see them on the screen, and it helps to better connect. So if someone's just not getting it, I can have them go on the biofeedback, and I can say, okay, so squeeze. You see that muscle? Whatever you just did, that is correct. Good job. Let's keep doing it. The real-time ultrasound is this picture that you'll see next to it. Okay, so this is someone's bladder, and what we can do is I can say, okay, squeeze the muscles, and we see what happens here. I say relax, and then we can also do the abdominal cavity and a bunch of other muscles as well. But again, it's just a different way, another way to connect to the pelvic floor, especially if you're like, I don't know where those muscles are. I don't know, wherever you tell me it is working. But there's lots of different strategies of, okay, imagine this, imagine that. Let's see if we can pretend that there's a jellyfish and we're floating up and we're relaxing, or a claw machine at the carnival and squeezing and relaxing. A lot of different strategies and tactile cues of, okay, squeeze here, don't squeeze here, to see if we can get those muscles stronger. All right, so here's some of the examples of exercises. So happy pelvic floor also has happy hips, abs, glutes, back, everything, okay? So we do a lot of ab work, we do a lot of glute work. So we have some bridges, we've got some leg lifts, we've got some bird dogs and dead bugs, and exercises for the core. And lengthening exercises are for those of my friends who have a lot of tightness. So we're going to do a lot more yoga poses to relax muscles, lengthen muscles, so that we can strengthen them later on. So if someone comes in and they have incontinence, but they also have pelvic pain, we address the pelvic pain first and then the incontinence. So we have to lengthen to then strengthen. So here's just some of the examples that we might be doing in pelvic floor therapy for incontinence. Okay, so how do I get into pelvic floor rehab? So you can talk to your PCP, but most of our referrals will come from a gynecologist, a urologist, or a urogynecologist. And you can just say, I know we don't talk about this all that much, but I'm leaking a little bit and I'd like to see if we can do something. There are surgical procedures, there are medication as well, but kind of first line of defense is a rehab. Let's see if we can strengthen, lengthen, and get better that way, talk about habits, etc. Get a prescription for pelvic floor therapy. I will say at Hackettstown, where I work, both pelvic floor therapists, we are both occupational therapists, and the rest of the system has physical therapists, pelvic floor therapists. So your script might say pelvic floor physical therapy. When you call central scheduling, you can just say, oh, I'd like to go to Hackettstown, and then they work on changing the prescription to occupational therapy. Both OTs and PTs kind of graduate as generalists, and then we do additional schooling to pursue pelvic health. So yes, the difference between Hackettstown is we are both OTs, so the script might look a little bit different. But that should have the script with OT, PT, pelvic floor therapy, whatever, and then your diagnosis, and then you call central scheduling to get on the schedule.
All right. Well, thank you everyone for joining us today. We kindly ask that you take a few minutes after today's webinar to complete the program survey. A link to the survey will pop up once the meeting ends, and it's also been added to the chat for your convenience. And a special thank you to Jenna for dedicating her time and her expertise today. If you have additional questions or comments, please send an email to communityhealth@atlantichealth.org or call 1-844-472-8499. That concludes our webinar. Have a good day, everyone. And thank you again, Jenna. This was excellent.
Thank you guys, everybody. Have a good day.